Hello everyone, my name's Chantal Maloney. I'm one of the sexual health nurses from Melbourne Sexual Health Centre, and today I'm doing a presentation on sexual history taking. Today's session overview includes why do we take a sexual history, the principles of sexual history taking, what questions do we ask when we take a sexual history, and the final part of the presentation will include 7 scenarios related to sexual history taking that you can do in your own time. Why do we take a sexual history? So the first point, to engage and develop a rapport with the client, is the most important. If we develop a really good rapport with our patients, it's more likely that they'll be open and honest with us when they're answering the sexual history questions. And this in turn gives us an accurate sexual history where we can determine the patient's risk and identify which sites we need to test from and which tests we need to do. It also helps us to determine whether there are any gaps in the patient's knowledge, and this provides us with the opportunity to educate the patient on those gaps. So there are some important considerations when doing a sexual history. It's important that we reflect on our own beliefs and attitudes. We know that people's past experiences may shape their beliefs, and that's fine, but it's very important that we don't bring our own judgment into the consultation. We can acknowledge our beliefs and our feelings, but putting those aside to make sure we don't let that judgment impact our relationship with the patient or the rapport that we're trying to build is really essential. It's important to have a private environment, so no noise or distractions, and being mindful that there's no other people close to the space that you're in that may overhear the confidential information or conversations that are happening between you and the patient. We need to consider confidentiality and its limits. So when we're having a consultation with a patient, we always discuss confidentiality at the start and explain that we're bound by the confidentiality rules, as any health professional is. However, there are times when we may need to break that confidentiality. And this may be at a time, for example, if your patient was a minor and you felt they were at risk to themselves, or perhaps if they'd been sexually assaulted. We can't develop a good rapport with a patient if we're not honest with them, and that's why talking about confidentiality and its limits at the start of the consultation is really important. Other important considerations include using language that's non-judgmental and an awareness of cross-cultural issues. So we need to be aware of patients' cultural beliefs, values, and any issues that might arise based on cultural issues. Now we're going to talk about all the things that we'd chat with the patient about when taking a sexual history. So I like to start with the least confronting questions in order to build a rapport with the patient, and then move into the questions around sexual history after you've done the medical history. So we start by asking the patient about their medical and surgical history and mental health history, whether they have any allergies, whether they're taking any current medication, including complementary medicines. Do they know if they've been vaccinated for things like hepatitis B, A, and HPV? We ask them what gender they identify as and what gender they were assigned at birth. So you may have a patient who was assigned male at birth but identifies as female, or vice versa. The information that's important to us is what genitals does the patient have, because that will determine what type of testing we'll be doing. If contraception is relevant to the patient, we ask about that. Are they using contraception? What type of contraception is it? Are they using it correctly? If someone, for example, is on the pill, are they skipping or missing, forgetting pills? If they're using condoms for contraception, are they using those correctly? With their menstrual history, we want to know about their periods. Are they regular? Have they changed at all? Are they heavier, lighter? Are they having any pain? Menstrual history is really important to know because you may pick up bleeding in between periods when you're taking a menstrual history. For example, if someone says, I'm getting extra periods rather than just my monthly cycle, I'm getting a bleed in between. Now, bleeding in between cycles is an indication sometimes of an STI, and that's why it's important to go through this with the client. We're going to ask them about past pregnancies, whether they've had any, whether they've had any miscarriages, whether they've had any terminations. And we want to know their CST history, that is their cervical screening test history. When was the last time they had a CST? Have there been any abnormalities in the past? When are they due for their next one? We want to know when their last STI screen was and what sort of tests they had done at that last STI screen. You may have a patient come in and say, yes, my last STI screen was just a month ago at the GP, but when you delve a little further and ask them what tests they had, it may just be that they had an HIV blood test and they haven't had a urine test or throat swabs or rectal swabs for chlamydia and gonorrhea. And they may not have had a syphilis test included in their blood test either. So it is really important that they are specific about what tests they have had done and when. You want to find out about previous STIs, whether they've had any in the past, when was it treated, and where, and how was the STI treated, and have they had testing afterwards to confirm that there is no STI there anymore. This is particularly relevant for STIs like syphilis or even MG, that's Mycoplasma genitalium. We want to know about any history of alcohol or other drugs. Do they have a history of drug use? And is that impacting their choices with their sexual health? For example, when they're under the influence of alcohol or other drugs, are they less likely to use protection? We also want to know about their history of trauma or sexual assault. Sexual contacts. When we're talking to the patient about sexual contacts, we first want to know about their most recent sexual contact. Was it a regular partner or a casual partner? When was it that they had sex? Was the partner male, female, trans? Was it more than one person? Was it multiple partners? What type of sex did they have with this person or these people? Was it oral, anal, vaginal sex? If it was anal sex, was it receptive or insertive or both? And some people call that versatile. Did they use condoms at all? And if so, were there any slipped or broken condoms? And are any of their partners men who have sex with men? Because obviously that puts them into a higher risk profile. It is important never to assume things with people or patients. So if someone says their last sexual contact was their regular partner, don't assume that they mustn't have any casual partners as well. And vice versa, if someone says their last sexual contact was a casual partner, don't assume that they don't also have a regular partner. We want to know how many partners they've had in the last 3 months and the last 12 months. Were there any sexual contacts from overseas? And when we ask this question, we're particularly interested in whether their contacts are from high prevalence countries. They are countries that have a higher risk of HIV, and these are countries like, for example, Southeast Asia. Does the patient have any history of sex work, and is this current? And if so, are they working in a legal brothel, or are they doing private internet-based work, or are they doing street-based sex work? When doing a sexual history for a patient, we also want to build a BBV or blood-borne virus profile of the patient for people who inject drugs. So if the patient is injecting drugs, are they using it recreationally, or is it habitual? What do they use? Are they using ice? Are they using heroin? How do they use it? How often is this occurring? What's their injecting practice? So do they always use clean needles and equipment, or are they sharing equipment like spoons or needles with friends or other people who inject drugs? Is this impacting on their sexual behaviour, and are there any referral options that they would like us to give them? We're looking at tattooing as well. If someone has a tattoo and it's been a professionally done tattoo in a professional parlour where they know the parlour used clean and single-use equipment, then that's fine. But we do want to know about any tattoos that have maybe been done overseas, in prison, in someone's backyard, in their home. So that obviously poses a risk for something like hepatitis C if that equipment has been shared between different people. Body piercing is the same as with tattooing with regards to the equipment used. We're interested in any blood transfusions or donations. So have they ever had any blood transfusions? And if so, were they in Australia or were they overseas? Have they donated blood? Donated blood is automatically screened for HIV, syphilis and hepatitis. And have they had their vaccinations for things like hepatitis B? So now we're going to look at taking the history of a woman with symptoms. We want to ask about vaginal discharge. We want to know whether the discharge is different to usual. Every person will have a normal discharge which changes throughout the cycle, but we particularly want to know if there's been any change to things like odour, consistency, the amount, is it itchy, is the colour different, is there any blood in it at all? We also want to know about any dysuria, so burning when you urinate. Although this symptom is very common with UTIs, it is also a common symptom of an STI as well. We want to know whether they have any pain with sex. Is it lower abdominal or pelvic pain? When was their last normal period? Is there any bleeding in between their periods? Or is there any post-coital bleeding, that is bleeding after sex or with sex? And have they got any lumps, bumps, ulcers or rashes? When we're taking the history of a man with symptoms, we're wanting to ask about urethritis, so inflammation of the urethra. We want to know about any redness at the meatus, which is the tip of the penis. Do they have any urethral discharge? And again, like women, if they do have a discharge, is it thick, thin? Is it painful? Is it yellow, green, clear, milky coloured? And that can give us a sense about what STIs we might be thinking about. So yellow or green discharge might indicate something like gonorrhea, whereas clear or cloudy discharge may be more indicative of chlamydia. Often men with STIs like chlamydia or gonorrhea will have dysuria or discharge. We also want to know about whether there's any testicular pain. Do they have any rectal symptoms? And these include things like pain, bleeding, and discharge from the bottom. And do they have any lumps, bumps, ulcers or rashes? On the final few slides here, we have a template for sexual history taking, which we use at Melbourne Sexual Health Centre. You can use this in your practices or amend it to suit you. That brings us to the end of the presentation today. Thank you to Carly Schreiber for providing slides for today's presentation, and I hope you enjoy going through the scenarios here with one another. Thank you.